Good afternoon from Nepal. This is Dr. Hira Burhan, President of the Asian Medical Students and Residents Society for Neurosurgery. I'm bringing you the Fujita Alumni Association Online Symposium 2018. This symposium is to connect all the fellows and the participants who have been a part of Fujita Health Network together, and so that we can start our first web conferencing through this platform. So first, we will like to introduce the panelists. Dr. Nasir, can you please introduce yourself? Dr. Nasir. Okay, Dr. Ajmat, can you introduce yourself, please, from China?
Hi.
Hello, yes, Dr. Ajmat, please introduce yourself.
Good afternoon. My name is Ahmad. I'm first year neurosurgery resident from Nanjing Medical University.
Okay. Hi, Dr. Ajmat. We start with a message from Professor Yoko Kato. She is the president of the Asian Congress of Neurological Surgeons. We are privileged to have her as our mentor, and she is the one who initiated the Fujita Alumni Web Symposium. I'll be sharing my screen, and I will show the message she has sent to all of us. John, can you see this? Can you see this, John?
Yes, I can see it.
Okay. So this is our program for today, Fujita Alumni Association. We start with a message from the opening remarks by Professor Kato. Dear colleagues, thank you everyone for joining this webinar for Fujita Alumni Association of Neurosurgery. Nowadays, technology is evolving in the field of neurosurgery. Just a second. Including preoperative imaging studies, device-assisted surgeries, post-operative care, consultation using telemedicine and technology for medicine or genetics. So young neurosurgeons should be updated and follow this knowledge to take care of our patients. This can be very challenging in some areas with limited resources. However, if we eagerly strive together to provide the surgical knowledge, idea, surgical skills, and the ways to connect neurosurgeons, we can achieve this goal. About the fellowship program of the Banvatan Hotokokai Hospital, Fujita Health University was established the International Neurosurgery Fellowship Training Program following the WFNS Training Center criteria back in 2014. This program is designed for a duration of at least 1 month, and till now, 50 fellowship trainings have been provided. Almost all of those fellows were young neurosurgeons who came from around the world, including India, Indonesia, Thailand, China, Italy, Malaysia, Uzbekistan, and the United States. Moreover, we are accepting and promoting female neurosurgeons from many countries to have this opportunity to learn. The Fujita Neurosurgery Alumni Association is elected for formal bylaws. The president, the secretary, treasurer, vice president are changed every 2 years. The membership can be taken by all the fellows trained at Fujita University. We also provide interim Fujita Health University alumni meetings in many countries, in part with international conferences. So I would like to invite all of you to this association. This web seminar is also one of our projects, and this can introduce effective learning through telecommunication. Not only is this beneficial to provide the knowledge, but also helps to build connections, which is one of the most important things that we can do it. I hope this project will succeed and it can continue in the next time for our society. Thank you very much from Professor Kato. So we now start our this mouse has some troubles.
You're still screen sharing, Hero. Just get off the
Yeah,
screen sharing. At the very top, just say get off screen sharing.
Yeah, but no, this mouse is not working. Oh yes, you need to.
Okay.
Yeah.
Okay, there you go.
Okay. All right. Having some troubles using Mac this time. For the first time, I am not used to using Mac, so
Okay, yeah.
Apologies for the inconvenience. Okay, so we would like to call upon Dr. Divya Palanisamy. She is a neurosurgeon from Chennai, India. She will be talking about an introduction and orientation to Fujita Fellowship. Dr. Divya, this is all yours now.
Yeah, hi. Yeah. So, 1 minute. I don't know. I'm just wondering. I'm sharing my screen. Are you seeing the slides, Hira? Can you see the slides?
Yes, we can.
Am I sharing? Okay.
Yes, excellent.
Okay. So I'm Dr. Divya. I'm from India. I did my fellowship at Fujita from March to May 2018. I thank Professor Yoko Kato for giving me this opportunity to talk. And I'm going to give a talk today, which will give an orientation to the fellowship at Fujita. Okay. So the aim of this fellowship is to train the young residents and young neurosurgeons from developing countries and also underdeveloped countries. So it is also to give an exposure for them to various subspecialties and advanced techniques which are practiced in Japan. So the fellowship, usually the duration is 1 to 3 months, and they provide you with a free accommodation in a stereotyped apartment, which is located very near the hospital. And they provide you with scholarship money, but that is given at the end of your fellowship. So when you come to Japan for the fellowship, you have to arrange for the money in Japanese money like yen as cash or visa card, and you will be reimbursed at the end of your fellowship. So flight ticket is our responsibility, and there is no travel expense involved because the apartment is very near to the hospital. So this is the Banbunten Hospital, which was built as the first building of the Fujita Health University. And this is the view which is taken from the railway station. So what are the images I have taken, I'm presenting today. So, and this is the stereotyped apartment. So it has a water kettle, and it has an electric cooker, and it has a mini fridge, and you have also an electric stove, so you can cook your own food. And during winter seasons, especially from September to March, it's better you bring blankets and sweaters and jackets and everything. It will be very, very cold. And so how to apply for the fellowship? So you have to go to the WFN's website. You have to do online application. You have to send. So go to www.wfns.org, go to fellowship application, select Fujita, and that will give you the details of the program and what are the documents that are required for the application. You can apply, there is a link for online application, and also you can contact Professor Yoko Kato in this email ID, neuron2@Fujita, HUACJP, and ykato@Fujita, HUACJP. Okay, so actually this fellowship is very busy. The schedule is very busy. Like they accept 3 fellows at a time. So you may get the reply from the secretary, Miss Toshiko knows, and but you will get the fellowship after 6 months or 1 year, since the schedule are almost filled. So wait for the reply from Toshiko knows. So once you join the fellowship, so it's very busy there. So be ready to become a busy bee. So the work starts on Monday morning at 7:30 a.m. with presentation of the cases for the week. What are the cases which are posted for surgery the next week and the other weeks? They're all written in the board in the fellow room. So you have to get the UHID and put it on the computer, get the images of the patients. A fellow has to make a PowerPoint presentation of all those cases, and the fellow has to do CFD, that is computational fluid dynamics, for the aneurysm patients. Those images should also be incorporated into the PowerPoint, and that will be discussed on the Monday morning. So Tuesday morning 7:30 we have journal club meeting. That is also comes in rotation. The fellows have to do that in rotation. And Tuesdays, Wednesdays, Thursdays or operation theater days. So if you are interested, with permission of Professor Kato, you can assist for the surgeries. On the same day, the surgery videos should be edited, because professor will present those edited videos to the patient and the attenders the next day morning. So that is very important, the video editing. So on Friday morning at 7:30 a.m., like there is a discussion will be happening on the edited surgical videos, and also the surgical steps are discussed, and which is followed by a short ward rounds, quick ward rounds. And video editing is important. The fellow has to bring a laptop, and a good video editor should be downloaded before going to Japan. That is very, very important. And means if you are interested in other surgeries, professor will arrange for that, like functional surgeries and all. She will find out which hospital they are doing, and she will allow you to visit those hospitals to visit those surgeries, to see those surgeries. And they provide you with some travel allowances also. And your fellow is expected to present, means write at least one paper during the fellowship. And if professor is organizing seminars and conferences, like you have to help her in organizing this, which will help you. So these are the means expectations from the fellows, like routines of a fellow. So what you can learn as a fellow from Fujita University. So yes, we are there to learn the management of neurosurgical cases. You will also learn how to means do computational fluid dynamics. I will come to that. And how to draw the aneurysms. And you can see different surgical instruments which are not available outside Japan. And you can also learn how to do microvascular anastomosis, and you have to means learn for the many fellows. That is a place where they learn how to write a paper. So, and there is a good library with good books and articles. You can access it, and you have access to JNS also, and you can develop your organizational skills. I will come to each with my experience. So yes, vascular surgery, we are there. Mainly vascular surgery is performed there. So both surgical and endovascular you can see there. And means many surgical techniques like anterior endarterectomy, Sylvian fissure opening, exposure of crinoidal segment of ICA, jugular tubercle resection, many surgical things, steps you will learn. Also they do revascularization, carotid endarterectomy, MBD, and all those things you are able to see. And endovascular procedures like coiling, and means the one which was interesting to me was middle meningeal artery occlusion for recurrent chronic subdural hematomas. So more than one recurrence they do this procedure. And this is the external carotid artery angiogram. You see the internal meningeal artery, means internal maxillary artery. This is the middle meningeal artery. You see the anterior branch and the posterior branch. So they are filled with means onyx. So it's not seen. So this was quite interesting for me. So you will also get to see many like this. And they also perform endoscopic surgery. They have an endoscopic arm, means robotic endoscopic arm. So you can see to that. And they do perform spine surgeries, skull-base surgery, tumor surgeries. You can visit specialized centers. So they practice in Japan. They practice subspecialty practice is there. So you can see the giants, big consultants in particular field. And apart from this, like you will learn how to do CFD, computational fluid dynamics. So it has 4 parameters: the pressure within the aneurysm, wall shear stress, vector and magnitude of the aneurysm, and velocity within the aneurysm. So this is CFD for a basilar apex aneurysm. So the pressure is very high, and the vector, the magnified view of the vector. Here actually, if the vectors are parallel to the aneurysmal wall, that means the wall is very thin. And if the vectors are diverging, that area is the wall is thick. So in Japan, actually we get to see more of unruptured aneurysms in elderly patients. So they do routine screening for all these patients. That's how they diagnose. So ruptured aneurysms are not common, means not very common in Japan, since they do the screening. So in these patients who are diagnosed during screening, so the CFD helps to know about whether to operate now or wait and watch. So this high pressure with thin walled aneurysms, they operate. So this CFD is done for MBD cases like trigeminal neuralgia, hemifacial spasm, and glossopharyngeal neuralgias. So this is to see the area of contact, whether a contact of vessel to the nerve is there or not. That is identified with CFD. And this is one of the right trigeminal neuralgia patient. So you see the superior cerebellar artery forming a loop and compressing on the root entry zone of the 5th nerve. And this CFD for these MVD patients is a little bit difficult, because we have to isolate the offending vessel. So that needs some training and some time. It takes some time. So you dissect the vessel, and this is after the CFD. This is the point. The red dot is the point where the contact is there. So this patient had a very good recovery after the decompression. So, and you also get to see use of intraoperative adjuncts like indocyanine green angiography and dual imaging video angiography, which is a recently introduced technique where the vessel with the dye actually looks green on the screen, so we can see the real-time relationship of the vessel to the adjacent structures. Perforators are all well seen. So endoscopy is commonly used in all the clipping patients to see whether the perforators are included in the clip, and whether the neck means there is residual neck at the end of the tip of the clip, so not to leave any residual neck of the aneurysm. So endoscopy is commonly used there, and I have seen brain oximetry used for carotid endarterectomy, and also they routinely use neurophysiological monitoring. All those things you can see and learn at Fujita, and this is one of the right CEA, and actually after the clipping, right side oxygen saturation was good, so there was no need for shunt. So this is aneurysm drawing. Actually, this was drawn by Dr. Ricky Tanaka, who was a senior resident at Fujita. He was there when I was doing my fellowship. So this in this drawing of the aneurysm, the intraoperative view of the aneurysm actually helps the residents to get an orientation during the surgery. So this takes 2 to 3 hours, but it really gives a good orientation. So you can learn this drawing also from there, and they have a separate book for that, how to do this drawing. And you can also get to see lots of surgical instruments, I told you. So the thing means, 2 instruments were quite interesting for me, like the rubber hook retractor. Actually, this retractor, they are using it to retract the skin, and then they use the same for retracting the muscle and also the dura. So there is no need for any assistant to retract retract. So this is very useful. And this is the instrument which is used for endoscopic surgery. Dr. Watanabe, he's the endoscopic neurosurgeon. So after excision of the pituitary tumor, he closes the dura, he sutures the dura. So to push the knot inside, he uses this instrument. So it was quite interesting for me. So you will get to see all those. And this is, you can also learn microvascular anastomosis, because we have a microscope. This is Dr. Niranjana, one of the fellows, and we have a microscope. So she's doing this learning how to do the anastomosis there. They provide you with the instruments and 10O or 9O suture material and all. So that is also one good experience for you. And then we have a good library, and you can use it for writing articles. And there are lots of surgical videos recorded in the hard disk for many years. So if you can access those videos, and you can store it in a hard disk. So better you bring one TD hard disk, that will be really useful. And editing the surgical videos actually gives you a good experience, like it revises the surgical steps that you have seen. So, and attending, if there are conferences happening in Japan, like professor will ask you to make the presentation, so it's a good opportunity for you to present posters or papers. So articles, you are expected to write an article. So I thank Professor Kato for motivating me to write these 2 papers, and these 2 got published, accepted for publication in World Neurosurgery. So organizing skills, you can also develop organizing skills, because when they conduct seminars and conferences, you are the one who has to do all the arrangements for that. So it helps you. And if you are good at organizing skills, actually professor promotes you to be the member of organization. Professor Aicherian is the Counselor General of ACNS, who was a past fellow of Fujita, and Dr. Balamurugan, Dr. Ahmed Ansari, they're all important members of the executive committee of ACNS. They are also past fellows of Fujita. And training of residents, like it was good to see that he's Dr. Miyatini, a young resident, like he's working under the microscope, exposing the aneurysm, dissecting the Sylvain fissure. Actually, Dr. Yamada, who is the assistant professor, will be around, and they wait for the residents to see, until the resident asks, "Sir, please take over and help me out." So he doesn't disturb the resident. This is the way they train the residents. So he is Ricky Tanaka, who was a senior resident there, and at the end of his training at Fujita, Professor gave him an ophthalmic aneurysm clipping. Like he did the anterior and he exposed the dural rings, and he opened the distal dural ring and he clipped the ophthalmic aneurysm. It was inspiring, and it's a good, it's different way of teaching I have seen in Japan. And these are all the other photographs that I have taken. We have taken Dr. Haraguchi and Dr. Ota. They are the endovascular neurosurgeons, and this is lunch with Professor Sano. And I was privileged to assist Dr. Takizawa, the skull-base surgeon, the best skull-base surgeon. So on the first day of my fellowship, so and it means for a VA Pica aneurysm surgery clipping. So like he taught me, he was so kind enough to teach each and every step of clipping from skin opening. So, and this is the fellow room, and Dr. Mayur Kamath from India and Dr. Fumin from Russia. So I'm thankful to both of them who helped me a lot during my fellowship period. And actually you get to know many people from Uzbekistan, Russia, many places like Thailand and all. So you develop lots of contacts with consultants and other fellows. That's a good experience. And apart from academics, there are lots of places to visit in Japan. You must be knowing, like this is the Buddha temple, and this is one palace, and lots of palaces, lots of temples are there. And this is a temple located in the hill. So the view from the hill is very beautiful. And there is a big aquarium. This is the outside view, and there are lots of events happening in the aquarium. This is one of the dam performance by the dolphins. And food and travel, actually professor is very kind enough to provide lots of snacks and noodles to the fellows, and that will be available in our fellow room. So for vegetarians who eats eggs, they will be able to manage in Japan. But pure vegetarians, it's very difficult. So I suggest them to take their own food and cook for themselves. For non-vegetarians, Japanese love food, and there are lots of restaurants in and around the hospital. In every place, every street has at least 2 restaurants, and they have lots of different country restaurants. So for Indians, so there are 2 restaurants at walkable distance, and there is a departmental store nearby. You can you can buy whatever you want for your house. And language, yes, they don't speak much of English. So that may be a problem, but I suggest you to download Google Translate before you come to Japan. So that will help you a lot. And Japanese are very kind people. So if you seek for help, even though they cannot communicate, they cannot speak in English, they will try to help you out. So they're very nice people. And the transport system, they have a very good railway system. So there is a railway station which is located near our hospital, and they provide the fellows with cycles, so you can do cycling also, use it. And bus is also available, but common mode of transportation is the train. And it's a very safe country, especially for women. Actually, we can walk on the road at 1 p.m. in the night, nothing happens. So seek for help. They are very kind people. They will be ready to help you. So professor very often takes you to the restaurants, and this is a photograph taken after the lunch, and this is a dinner, and this is a small restaurant near the hospital. So apart from all this, you can see the hard work by the Japanese people, and they give more respect for the elders and their teachers, and it's very impressive. And the cleanliness and the self-discipline, they maintain the queue and all those things, and they are very well organized. If you take the road or anything, it is very well organized. So you get to know about all those things in Japan. So this is my last day at Fujita. Actually, at the end, last day, you will be provided with a valuable certificate from Professor Yoke Keto, and also you can get a recommendation letter. So I am. This is Assistant Professor Dr. Yamuda and Miyatani resident, and Professor Kawasi. And I thank all of them for their support during my fellowship. And this is the farewell party. She is Toshiko knows, and she will help you a lot during your fellowship. You'll get to know once you join the fellowship. And so Fujita is a place of it's filled with lots of opportunities. So it's up to you to make use of it. And this is the temple near the our hospital. So welcome to Fujita to see the dance of Sadhans. Thank you.
Thank you so much, Dr. Divya. That was a wonderful orientation for all those who are new to Fujita and who are planning on to pursue a fellowship there. And it's really looks like a very welcoming place. So any comments, any questions, anything someone would like to add? Obviously, we have speakers who will be giving their own experiences about Fujita. So anything from the panel? Anyone? Achmad, Anyone would like to add something or comment on this? Dr. Divya, you need to stop the screen share, please.
I don't know how to.
It's on the top, you find a red option which says stop sharing.
Okay. Yeah.
Yeah.
Yes.
Okay. Okay, we see Dr. Alberto. He's here. Okay, so we move on to the next presentation. Thank you so much, Dr. Divya. And for everyone, Dr. Divya is the chairperson of the Women in Neurosurgery Committee, which has been started by by Professor Kato, and she's leading the Women in Neurosurgery chapter for the ACNS. So a round of applause. Okay, so we start. We go from here. We go to Russia. We have Dr. Abdul Rahman Al-Zahrani. He is resident of Professor Albert Sofyanov. He's practicing at the Federal Center of Neurosurgery at Tyumen. He will be giving an overview about the education in the Federal Center of Neurosurgery in Tyumen. Welcome, Dr. Abdul Rahman.
Thank you, Hera. Thank you. Good afternoon for everybody. Now we are talking now from Moscow. From Russia, Tyumen. My name is Dr. Abdul Rahman Al-Zahrani. I'm doing my training under supervision of Professor Albert Sofyanov. Now we will start our presentation about Federal Center of Neurosurgery. So, okay. Actually, the Federal Center of Neurosurgery in Tyumen was built in the framework of the National Project of Public Health of Russia. And that was at 2011. After that, actually, Professor Albert Sofyanov, he have developed more to high-tech surgeries and was conducted in the center for patients and it's accommodated patients for more than 80 regions of Russia and other countries, international countries. Now you can see the pictures. Now the Prime Minister, the Prime Minister is visiting our center, and also the government sectors they are taking care of our center as well. In our center, we have 95 beds, and this is just divided to several sections or several units. One is functional neurosurgery, and we have for functional neurosurgery 20 beds. And also we have neuro-oncology department. We have for that 20 beds. And we have spinal neurosurgery, and we have for that also 20 beds. And we have cerebrovascular neurosurgery, and we have for that as well 20 beds. And pediatric surgery, and we have for that 15 beds. Beside this, we have our own independent neurosurgical intensive care unit, and for this we have 12 beds. Surgical units, we have 7 operation rooms, including 1 X-ray angiography system. We use also very high-tech equipments. Intraoperative CT, ORM, and angiographic system. This is also intraoperatively used. Microscopes, we have high qualities and the best qualities, Carl Zeiss. Benetro, we have also 3D cameras, intraoperatively can be used, navigation, as well as we have brain lab, endoscopic standards, stand source, and Escolab. We have intellectual hybrids operating room with full control, which can be used more for the tumor cases, and can be also screened during the operation. In our center, actually, we have established first to do some not easy cases, actually, like road papilloma, third ventricle, and also can be used endoscopical, removal for choroid papilloma. And also that we have, this is our patients pre-op and post-op. This actually was first done some studies for that, and cover of the leading now journals of pediatric was in 2015. Shows the steps of our neurosurgical department. We have performed such cases, and it was taking the steps of the whole neurosurgical step. This was Professor Albert Sofinov, who was operating the also intrapetal, fetal hydrocephalus was also done, and this usually will make it possible to carry the baby full term. Actually, our department is belong to Soshenap University since November 2016, and it became the clinical base for academic department of neurosurgery of Soshenap University in Moscow. As we know, also the strong clinical base make usual successful of neurosurgeons. So for this part, we have practical training in academic department of neurosurgery. This was including simulations laboratories, which can help for developing the skills of the new residents, and we have also using the cadaver laboratory. During that, we can see also the anatomical studies and microsurgical and endoscopic approaches with hands-on training. We have also full body cadaver laboratory. We can use for that one also microscope and endoscopic approaches can be done. Hand-on training on spine and peripheral nerve and vascular system as well. And we have veterinary laboratories used also for that by using rats, and this is usually used to improve the skills for microsurgical anastomosis as well. That we have 3-dimensional live surgeries usually done under audio and live stream. We have our independent section also for photo and video laboratory. And we are using also the simulators for surgeries, as you can see in this picture. We have actually participated in a lot of publications and native illustrated handbooks. As we can see, this is all under supervision and of Professor Albert Sofinov, as we can see it here in these pictures. This is our microsurgical laboratory. We have around 12 microscopes, and we have also some cadavers we are processing for long time courses of skull-based surgery, and also endoscopic surgeries and spinal surgeries as well. This is usually under the guidance of high professors. They used to come from outside Russia, America, India, Nepal, Pakistan, from so many areas, like Germany. As we can see also in this picture now, our skull-based course was, one of our guests was Professor Barba from Brazil, and Professor Venko Dillons, and so many professors actually used to come to share our success in our skull-based courses and endoscopic courses as well. And this is for the full body cadaver laboratory used for dissection, table and video and also the C-arm can be used during the dissections, and endoscope, a microscope as well. So it is a fully equipped room. We can use that for full body cadaver laboratory. Now we have also courses for spinal surgery and we are mostly specialized for the craniovertebral junction areas. We invite professors from outside the country, as we can see in this picture here. This is the trainees used to come for pathology laboratory, also for the full body, as we have mentioned before. This is the section for rats for microanastomosis. Actually, in our operation rooms, we use very high-tech equipmentation and instrumentations, as well as you can see here in this picture. And 3-dimension courses, we can see it by 3-dimension ways and 2-dimension as well. Actually, our course is worldwide known now under the supervision of Professor Albert Sofyanov, and also we used to have some good combination for that when Professor Barba or other colleagues come to our center here for presentations. This is our trainees. In the video, this is our laboratory, and our Professor Albert Sofyanov is the leading one for microdissection areas. Now, actually, our neurosurgical center became one of the international societies. We have shared in 33 international conferences with educational courses also have been conducted. More than 930 doctors was also from 31 countries have been trained here. As we have mentioned, actually, this department is belong clinically for academically for Sishenov University, which is located in Moscow, and it is one of the best universities here in Russia, recognized internationally as well. So this is our trainees come for the courses, after courses, and they have some lectures with Professor Albert Sofyanov and the guests as well. They used to have a certification after courses. This is our guests. Also, now we have some training courses for the macrovascular and endoscopic and aneurysmal regions. We can do also some training for that here. This is our address and all what might be somebody need to know about the center. So this is our contact numbers, telephones, and our website, and also Viber, WhatsApp. So it is very easy to contact our department here. Head of the department is Professor Albert Sofyanov. Now we have our international education course for minimally invasive neurosurgery. Usually yearly can be done between November and this is our coming course, will be after 2 weeks around or less than 2 weeks. So we are welcoming all for visit and for having this enjoyment for the training here. Thank you for your attention. This is Dr. Abdurrahman from Germany again.
Thank you so much, Dr. Abdurrahman. That was a wonderful introduction about the Russian Center for Tyomin. I suppose you have a lot of audience from Russia at the moment.
Yes, actually, it is belong to Moscow area. First, if somebody want to study here, he should apply first to Moscow, and from Moscow they will send to main area.
Okay, that was a wonderful presentation. Thank you. We have one of your residents, I think Ibrahim is with us, so he would like to share any of his experiences.
Ibrahim is here.
Hi Ibrahim. Hi, how are you?
How are you?
Hi, I'm good. Please introduce yourself and tell us about your experience at Tyomin.
Here is good. I'm so happy.
Okay. So yeah, it is indeed one of the most. We have had faculties going from Pakistan as well to Tyomin. I've always heard best about this. I hope to come to you guys sometime. Yeah. Okay. We have from our panelists, we have Dr. Leonardo. Can you please introduce yourself, Dr. Leonardo? Dr. Leonardo, can you hear us?
Okay.
Hi, you need, yeah. Please introduce yourself to us.
Are you listening me?
Yeah.
Yes,
We can listen.
Best greetings for you. I'm from Colombia. Right now, I'm resident of neurosurgery in the Human Neurosurgical Federal Center here in Russia. And well, it's amazing, foreign people for other centers who get them the high technology training. Thank you for the opportunity to listen to you and to see you and know about your perspectives.
Thank you. You're welcome. Dr. Nasir, can you hear us now? Yeah, you need to unmute, please. Please unmute. Yes. Please introduce yourself, Dr. Nasir. We cannot hear you well. Okay, maybe there's some problem with the connection. So any questions or any comments for Dr. Abdurrahman on his talk about the Tyomin Center for Resident? Any questions? Anyone would like to ask anything to him? So we proceed with our next presentation, that is Dr. Alberto Fileti. He's joined us today. He's from the Modena University Hospital, Italy. He will be talking about the navigation of the cerebral aqueduct and the fourth ventricle. Dr. Alberto, could you please screen share and start your presentation? Can you hear us well? Yeah.
Yes, I can hear you.
Okay.
Let's see.
Yes, you're well connected. Yep.
Yeah, good. So, okay, can you see my presentation?
Yes. Yeah, we can see that.
Okay.
Yes.
Okay, very good. So, good morning to everyone. My name is Alberto Fileti. I am a neurosurgeon working in Italy, in Modena, which is a city in north part of Italy. I have been a fellow with Professor Yoko Kato 2 years ago. So I will talk to you today about the navigation of the cerebral aqueduct and fourth ventricle with a flexible endoscope. As you all know, in the past, ancient Greeks thought that the world was flat, and they also thought that the western limit, the western border of world, was constituted by the Pillars of Hercules, which is a place that nowadays we know as the Strait of Gibraltar between Spain and Morocco. So it was forbidden for human beings to move over that limit because it was considered dangerous and nothing could be found besides water. And for many years, the cerebral aqueduct has been considered like the Pillars of Hercules for neurosurgeons and for neuroendoscopists, even after the introduction of the flexible scope. So only the adytum of the aqueduct could be seen, as you can see from these two pictures. But in the recent years, we and other groups showed that it is actually possible to navigate the cerebral aqueduct with a flexible endoscope. And it is possible if you are, of course, if you have a good expertise in handling an endoscope, and if the cerebral aqueduct is not stenotic, of course. It is possible in a safe way. This is a short video showing you the navigation now of the third ventricle. This is the abenaural commissure, posterior commissure, the adytum of the cerebral aqueduct that we are actually passing now. Now we are navigating through the aqueduct. And finally, we enter the fourth ventricle, and we can see the choroidal plexus of the fourth ventricle, cerebellum, here, and the Magendie foramen. So this is possible with a flexible scope. What can be done with flexible scope? Many things, actually. Of course, third ventriculostomies and biopsies, but I will not talk about that to you today because it's possible to do these procedures also with rigid scopes. I don't know if my presentation moves on. Okay, so I will skip this part because it's possible to do that only also with a rigid scope. What else can be done? In some selected cases, we can aspirate, like in this case that we published, we can use the working channel of the flexible scope as a sucker, and we can remove the tumor, if the tumor, of course, is small, not more than 2 centimeters and soft. And we can remove these tumors from the posterior part of the third ventricle and also from the aqueduct. What else? We can manage arachnoid cysts. Look at this case. This patient had a huge cisterna already in the fourth ventricle. We are sliding our endoscope in between the roof of the fourth ventricle and the floor of the ventricle. This is the brain stem, of course. See how narrow it is because of the compression of the cyst. And then finally, we see the canalis centralis medullaris there and pike, and then the wall of the cyst, which is here. We always check very carefully the wall of the cyst to see if it is transparent, because it's important to try to understand what's behind the wall before making the first hole, which is this. Okay, we made the first hole in the wall of the cyst. Then usually we try to enlarge this hole with a balloon, or sometimes we try to shrink the wall of the cyst using monopolar coagulation. This is the final view with the Magendie foramen, cisterna magna, which is free now. And we are withdrawing the endoscope. You can see how much larger fourth ventricle is after the fenestration. It gained a normal anatomy again. Then, of course, we performed also a third ventriculostomy in this patient. Also, aqueductoplasty can be performed with flexible scope. When I talk about aqueductoplasty, I'm not saying I am
Okay, I think we have a little freezing of the Wi-Fi. Can you hear me, anybody?
I can hear you, Dr. John.
Okay, yeah, we're having a freezing there of the presentation. Are you there, Hira?
Oh, can you?
Yeah, okay,
can you
go
hear
ahead.
me?
Yeah, go ahead, Alberto. Continue.
Okay, I don't know what part you missed. I was talking about aqueductal stenosis. We treat with transaqueductal navigation only those stenosis that are due to membranes. Like in this case,
Dr. Alberto, sorry to disturb you. Actually, your slides are not shown. They are not shared.
Oh, wait, let me check.
Yeah, you're not sharing it.
What's the problem?
Yeah, thank you for bringing that up, Disha.
Wait. Let me see if I can share again.
Yeah, there you go.
Yeah, sorry. I'm in China right now, and the connection is really bad.
It's okay. We're getting through.
So
we can see it now.
Okay, let's see if I can make it work. Can you see it?
Yes, we can.
Okay. Okay. So you can see. Okay.
Yes.
So here in this video, I did you can? Okay. In this video, I did a perforation of a thin membrane, which was the cerebral aqueduct. Of course, I used a balloon fenestration, and then you can actually navigate the fourth ventricle. In this case, we know
I guess we have another delay by the Wi-Fi connection of Alberto. I believe he's in Russia now. Go ahead, Hera.
Yeah, there was a problem with his connection because of this firewall thing. So I think he's having trouble with the internet connection at the moment.
Okay.
I think we just wait for a while until he gets back.
Okay.
Yeah. Okay.
It came through the last time. This is the unfortunate part of Wi-Fi. It's inconsistent. We never know if it's going to work. So Alberto's in Russia now. Or China now.
Yeah.
He's in China. Can you hear me, Alberto? Can you hear me?
Yeah, I can hear you.
Okay, you dropped off. You dropped off there at the end of your presentation. You want to finish it off?
Oh, okay. Can you see my presentation right now?
Now I can. Okay, you got a screen share.
Okay. So I was saying that in this case, it was very dangerous to perform a third ventriculostomy because the brainstem was pushed against the clivus, and also the basilar artery was obstructing our view.
Dr. Alberto, sorry to interrupt you. Again, the slides are not. The slides, we are not seeing the slides. It's not shared.
Oh my God, wait. Let me check again. Let's try again.
There we go.
Okay, you can see them now?
We can. Yes, we can.
Okay, in this case, we considered the third ventriculostomy to be pretty dangerous. So we navigated through the cerebral aqueduct and we noticed the obstruction of the Magendie foramen, and we did a Magendie-plasty, and the outcome of the patient was very well. But I think the most interesting application of flexible scope is the aspiration of intraventricular blood hemorrhage. As you know, intraventricular hemorrhage is a very challenging disease with a very high mortality rate. The standard treatment is external ventricular drainage. Of course, it's a very simple procedure, and it allows a fast resolution of acute hydrocephalus, but it must very often be bilateral. It frequently obstructs, and you have to wait a long time before the blood is washed out. So the stay at the hospital is very long, and you can have many complications. We showed that removing intraventricular clots with a flexible scope decreases mortality and decreases VP shunt dependency in these patients. So just some examples. See, this is a preoperative scan of this patient with intraventricular hemorrhage, and after endoscopic treatment, we can obtain a complete resolution of this intraventricular hemorrhage. Notice the fourth ventricle, which is completely free of blood in this case. This is possible only with flexible scopes, using the operative channel of the scope as a sucker, and with a very simple instrumentation like a syringe to do aspiration, and of course ringer lactate for irrigation. The access is a frontal precoronal bar hole, which must not be too lateral. Otherwise, it's difficult to introduce your endoscope in the cerebral aqueduct. Just two maneuvers are important for this surgery: irrigation to make the field more clear, and aspiration to remove the clots, of course. Initially, this kind of surgery can be very frustrating because you can see only red when you enter the ventricles, of course. You see only blood, but finally some landmarks appear, like this, in this case, the choroid plexus, and you have to follow the choroid plexus until you see the Monroe foramen, and then you keep doing aspirations and irrigations until you set the third ventricle completely free of blood, like in this case here, the optic chiasm. Then you direct the endoscope to the posterior part of the third ventricle, and then you keep doing aspirations and irrigations, and finally you will see here the aqueduct, the adytum of the cerebral aqueduct, posterior commissure, abenular commissure. You can even see the roof of the third ventricle, and then of course you have to enter the cerebral aqueduct and aspirate the blood from the fourth ventricle. And finally, after the aspiration, the complete aspiration of the blood, you will be able to see the Luschka foramen with its choroid plexus, and also the Magendie foramen. In some cases, we perform coiling and neuroendoscopy in a very short time. So you can obtain, you can secure the aneurysm, of course, with coiling, and you can obtain the resolution of intraventricular hemorrhage in a very short time. Look at this case, basilar artery aneurysm. It was coiled, and then after neuroendoscopy, see the blood is completely disappeared from the ventricles, even from the fourth ventricle. In very selected cases, we can navigate the cerebral aqueduct from the fourth ventricle. In this case, we operated this patient with a tumor in the posterior fossa in a prone position with a microsurgical technique. It was a very bleedy tumor. So at the end of the surgery, we wanted to inspect the ventricular system with a flexible scope. So now we are in the fourth ventricle, and we are entering the cerebral aqueduct from the fourth ventricle. This is a very unusual view. This is the aqueduct, and in a few seconds, we are going to see the third ventricle. This is the posterior commissure, and this is the adytum of the cerebral aqueduct. We entered the third ventricle, and actually we have seen a blood clot. Of course, in the prone position, blood for gravity can enter the cerebral aqueduct and the third ventricle, and it's a potential danger, because these clots after surgery can obstruct the cerebral aqueduct and give acute hydrocephalus. So we aspirated these blood clots from the third ventricle. You can arrived until the Monroe foramen, like you can see in this case. We aspirated blood from the Monroe foramen. And with the same technique I showed you before, aspirations and irrigations, we finally obtain the complete release of blood from the third ventricle with a very unusual anatomy. Here you can see the two foramina, the anterior commissure and the infundibulum. Here, this is the optic chiasm. Okay, and just to conclude, if we use fluorescent sodium, intravenously injected fluorescent sodium, and a special filter for the camera of the scope, we are able to see what is otherwise impossible to see inside the ventricles. The first anatomical structure that we can see with this technique is the subependymal vascular network. Here you can see the choroid plexus, which become fluorescent. And here, I don't know if it is possible for you to see this tiny vascular subependymal network, which is impossible to see with normal light. But probably, and I will finish with this slide, the most interesting application of fluorescence is to detect the presence of the circumventricular organs, which are very strange structures that cannot be seen with normal lights. Here, this is the tuber cinereum. With fluorescence, you can see area postrema. You can see the median eminence and also the organum vasculosum lamina terminalis. This is lamina terminalis. Again, tuber cinereum and median eminence appearing with fluorescence. And beyond the pillars of Hercules, actually, so in the fourth ventricle, we can also see a circumventricular organ, which is located in the inferior triangle of the fourth ventricle. Here we are entering the fourth ventricle, choroid plexus of the fourth ventricle. And now, with fluorescent mode, you can see these two leaves. This is the area postrema of the fourth ventricle, which is not possible to see with normal light. This is the canalis centralis medullaris. Okay, thank you very much. And sorry for the technical problems.
That's okay. That was a nice presentation, Dr. Alberto. We are glad you made in time.
Thank you.
Yeah. Any questions, any comments from the panelists for Dr. Alberto?
Dr. Alberto?
Yes, Dr. Divya.
Yeah, it was very impressive. And seeing the circumventricular organs, yeah, it was very good. So one thing I want to know from you, you remove the intraventricular hemorrhage through the endoscope using the flexible endoscope. And means what is the outcome? Like, does it reduce the, what is the better outcome you saw? Removal of the blood clot without removing and with removing. Is there any difference in the occurrence of hydrocephalus or?
Yeah.
What difference it makes? Just want to know.
We performed a comparison between patients treated with endoscopy and patients treated just with external ventricular drainage. And we noticed that the length of stay in ICU was shorter for patients treated with endoscopy. We also noticed that the outcome was better. We used the Glasgow outcome scale to perform this analysis. And we also noticed a decrease in VP shunt dependency in patients treated with neuroendoscopy. Of course, there is a bias in our comparison because we compared patients which were treated with ETV years ago, because after the introduction of the flexible scope, we always use flexible scope for intraventricular hemorrhage. So there is a time shift between one group of patients and the other group of patients. But there are evidences in literature that endoscopy can actually improve the outcome of these patients.
Okay, and means once you go in, like, did you encounter any complication, because everything is red? Like any complication which you encountered with endoscope?
Yeah, of course, the major possible complication is intraoperative bleeding. But in my experience, and not only in my experience, also in the experience of my former mentor, who taught me how to use the flexible scope, if you encounter a bleeding in the ventricle, you don't have to panic. You just need to keep doing irrigation. So irrigate, and wait, irrigate and wait. I was always able to stop the bleeding just with irrigation.
Okay, fine. And like, how do you change the direction of the flexible scope? Like,
okay, good question. The flexible scope has like a handle you can use to move the tip this way, up and down. So for up and down movements, you can use this tool, which is controllable with your hand. But also you can use the other hand to slightly rotate the endoscope, so you can change this direction. Okay, rotational direction.
Okay, thank you so much, Dr. Alberto.
Sure, thank you.
Thank you so much, Dr. Divya. Any other question, any comments from anyone else?
Dr. Alberto, thank you for presentation. It's amazing, it's cool. And I have a question. Can we use this flexible endoscope for transnasal operations? Transnasal, transvenous?
Well, I think you can, but I don't think it would be the best tool. I do transphenoidal surgery with rigid scope. Rigid scope it has a much better view. Probably you noticed from my videos that the vision is not very clear like a rigid endoscope, because this endoscope is made with fibers, fiber optics. However, I think 1 year and a half ago, both Olympus and Storz introduced a new flexible endoscope with a chip on the tip. So now the vision is like a microscope. However, I really think that you need a flexible scope if you have to deal with a complex geometrical anatomy like the ventricular system. But if you have a very straight way, like for transphenoidal surgery, I don't think there is any need to change from rigid scope to flexible scope, even because the flexible scope has a smaller working canal. So I think maybe you can use flexible scope at the end of transphenoidal surgery if you want to inspect some hidden corners of the surgical field. But I would not suggest to move from rigid to flexible scope for transphenoidal surgery.
Okay, thank you.
Okay, thank you so much, Dr. Alberto. Could you please stop the screen sharing and we proceed with the next speaker?
Sure.
Yeah. Okay.
And
yes.
Okay. And I have to say goodbye to all of you because I have another meeting to attend here in China. So thank you very much.
Thank you so much for joining and making it. Thank you.
Thank you. Bye. Thank you.
Bye. Next, we have Professor Cherian from Nepal. He's the director of the Nobel Institute of Neurosciences, Biratnagar, and right now he's with me in VR. He'll be giving a talk on robotics and neurosurgery. So here you go, sir.
Thank you, Hira. Hey guys, good to see you all. Hey John, How are you doing?
Good. How you doing, Ike?
Yeah, so, I was supposed to give this talk in Brazil a couple of months back, but I couldn't make it to Brazil because, um, 2 days before the Brazil meeting, I was in Ireland. So it was a bit of a difficulty to go to Brazil as well. But I'm very happy that I can give this talk here. Now, I don't want to go into technical details because if on an online talk, especially in the afternoon, if I'm going to technical details, I mean, that'll just get people to sleep more. So I'm just going to be telling people as to where we are and what we are capable of. Okay, that's exactly what I want to tell you guys. So, and I'll tell you where we are with our robotics project. So we are doing something with the University of Alicante and probably getting some investment from some Chinese companies. So we will tell you as to what we are doing at the moment. There's no point talking about robotics when you're doing nothing. Everybody can do that, right? It's like talking on aneurysm surgery if you're not doing aneurysms. So let me share my screen and I'll be able to show you as to this one. Okay, share. Right. Can you see this? Can you all see this?
Yes.
Yes.
Okay. Right. So robotics in neurosurgery. That's our present one of our 3 operation rooms. So we have, John has been there. So we have everything was what Albert has to in Tumen. So we have a navigable pentero microscope. We have the OARM for spine and skull base. We use it for spine and skull base. We have the 3 Tesla intraop MRI with I7 navigation, where we could do all the functional images and then navigate with that. We also have the endoscopy suite with the robotic arm. So this is current neurosurgery. In my place right now, we have everything what the other places anywhere in the world would have. So we could get the 3 Tesla intraop MRI, the fibers or the skull base with the O-arm, fuse everything and bring it to my microscope for picture in picture so that I can navigate before even the head is opened. I put the microscope, I know where the tumor is, I know where the aneurysm is, I would know where to open. So this is something that we have right now at the moment. But, in India, you say, dil mange more, which means you need more, okay? So is this where we are actually at with respect to, neurosurgery? This is the best we can get. But is this actually where we should draw boundaries and say, yes, this is the best in neurosurgery? No. So I am going to show you some of the robots, and then you will understand what the capability of robots are. And then I'll show you the surgical robots where people have attempted, and then due to this, FDAs and everything, by the time you try to get an approval, it'll take 10 years, and by that time it'll be primitive. So that's why everything in medical field gets to be primitive, almost 10 years off before you can start human trials. I'm not saying this is a disadvantage. Of course, you have to check things before you start operating, but this puts you at a major disadvantage. So let's see what robotics and artificial intelligence can actually do. So first thing is visualization. This is the robot that we have made. I will show you the visualization robot in the last slide of this presentation. I'll be happy to show you how visualization. You see, now you have a huge microscope in your front. Okay, you're operating with a huge microscope. The navigation is separate. So it is not linked to, I have the picture-in-picture for navigation, but the microscope visualization is not the navigation visualization. This has to change. So you will have to change it into a place where the virtual image and the real image has to be fused, just like a pilot lands his airplane in fog. So when you have fog, the pilot has a virtual image, so he doesn't have to worry about seeing actually the airport and then landing. So because he can see the virtual image and land. So if the aneurysm takes off, I mean, the aneurysm bleeds, you should be able to clip it because you should be able to see it. Virtual image you should be able to see. This is one thing where we can fuse visualization and navigation for a real, true versus a virtual image. Then you can have a robot like a Franca Amica. I'll be showing Franca Amica, where you can have it as a surgeon's assistant. You know, I use both my hands. I'm proud to be ambidextrous, but then I often wish that I had two more arms. You know, when you're operating, your assistant is not exactly in sync with you, then it's a big problem. So you think that you should have one more or two more arms. A robot can do that. Remote surgery and robotic neurosurgery suite is two ideas which I wouldn't really talk about, but maybe sometime later I would show you as to what I mean. But let's see the basic things. Now, I'm going to show you starting from craniotomy. Can a robot do a craniotomy? Can a robot do a craniotomy? Is it too complex for a robot? No, it is not. So you must see what is RoboSculpt. There's already there, complex shapes are being drilled out by this robot. This is a huge industrial robot. We're starting here. So a craniotomy is not difficult for a robot. If you can show on the virtual image as to what to do, if you can show on the virtual image, this RoboSculpt is sculpting clay. Okay, and you see what it's making. You see how the RoboSculpt makes things. Okay, so a craniotomy can easily be done. I mean, there are things to do, laser craniotomies now, but forget laser craniotomies. With drills, the robot can do a craniotomy maybe less than 10 seconds. Now, I'm going to show you Franca Amica. This is a robot that we are very interested in. We want to work with this platform. It's a $10,000 robot. We hope to have one soon. You see that? It can interact so beautifully. And it's so precise. You show it what to do. You show the robot to do something, and with AI, it can learn. So it is an assistant which will ever improve. Like your assistant, sometimes who will not keep on improving. This Franca Amica is a robot who can keep on improving. You show it something, it will learn it. Okay? So it can be used for many tasks, but amongst its many tasks, it can be a surgeon's assistant. Okay? So that's Franca. Next, I'm going to show you what AI can do in weaponry. Okay? So don't worry about this video. Don't worry about this video, but I mean, I put it because in military technology, AI is being used extensively for facial recognition. It can even, the small drone can even go and identify and deal with one person. So, you see, it can react 100 times faster than a human. It can recognize faces. It can make its own flight path. And see that. You think this is far away? You think this is far away that it can be used in, these kind of things could be used in neurosurgery? No, because The problem is nobody wants to change. The present day robotics that neurosurgery is using, let me show you. The new Zeiss Kinevo. Compared to what we saw, the Zeiss Kinevo is the new size microscope, robotic position, surgeon control robotics. At present, this is the best visualization robot that neurosurgery has. At present, this is the best visualization neurosurgical robot that we have. And to be frank, it's a joke, because the capability of robots in neurosurgery, it can be much more. Let me show you something. This is the Da Vinci system. Okay, another robot which was used extensively in urology and now being used by Paulo Porto de Mello and his group in Brazil for neurosurgery. A modification of this is being used in neurosurgery. But again, this is a very primitive robot, very primitive. And let's see the neuroarm, the only robot which actually made a lot of news by operating on a patient. My good friend Garnet Sutherland from Calgary, who's been instrumental in making this robot. So let's see this robot. That's Garnet and his team. That's his operating theater. That's a robot. So Garnet is sitting in a control room and he can operate this robot remotely. See that? He's got touch sensors. He's operating this robot. It can eliminate tremor. It can do very precise maneuvering through very small windows or very small corridors. And it's intra-op MRI guided. IMRIS intra-op MRI guided. But this never really took off. The neuroarm didn't sell too much because there were many points which were not really an advantage. Now, I would like you to see this video. Okay, this is not an exaggeration. I want you to see the entire video here. This is Timo Boll playing with a KUKA robot for table tennis. If any of you would have played table tennis, you wouldn't understand the kind of spins, the kind of speed, and the kind of skill that you require for playing table tennis. And this robot is playing with the world champion. So see this, and then you will be able to understand as to what this robot is capable of. If you ever thought that table tennis playing is just, you know, uh, touching the ball and putting it over the net, this guy is using side spin, top spin, back spin, and the KUKA robot is able to adjust its bat incline in such a way and the bat speed in such a way that it's able to combat. If you're playing a professionally good table tennis player, let me assure you, for the first 2 years, you wouldn't have a clue as to where the ball is going to go. But the KUKA robot is able to adjust this. I was very impressed. I played table tennis, so I was really, really impressed with this. So that was the video where the robot is playing the table tennis. But let's come back to my project, what I'm doing right now with the University of Alicante. So I will show you the visualization robot where we have two of these robots, one with a normal camera like a microscope camera and one with an endoscopic camera, both providing us a hyper-realistic image. We can fuse this into one to get a hyper-realistic image or have one by one. So this robot can be controlled by just head movements. I will show you that. This is the first prototype which is already ready. We want to replace this big robot with something like Franca Amica, so that instead of microscope and endoscope and navigation, we would have just one tool. And we call it the visualization robot. And there will no more be any 3D screens, because we would have it on the head mounted. We will have it on glasses. So anybody who's watching anywhere in the world can, with these glasses, can see what the surgeon sees. This is the precision, and I will show you how we control it. See that? This is Alvaro, our engineer. Alvaro is controlling it with his head movements. We have put a S7 navigation system. We literally, I must not say this, but we hacked it and we got it into the system. And see, the glions, we are using it for head control. So wherever the surgeon looks, the robot looks. And we can have firewalls, which means there are places where the robot shouldn't come to obstruct the surgeon. We can do all that. So this is where we are with our robot. But my dream is to make a complete robotic suite where the table is robotic, where the surgeon's assistants are robotic, the visualization device is robotic, the tools are robotic, except the surgeon, everything is robotic. The surgeon is at the center, and then we have a suite. It will be a big dream because it needs the kind of funding that you require is not small. So we need somebody like Google to fund it. So we're trying to pitch our ideas to many companies in China and see what we can do. We want to start off at this point. So, but I'm sure in 10 to 15 years, this would be the future. Robotics would be the future. There'll be surgeries which a lot of surgeons cannot do. So for example, we were doing a petroclival meningioma 3-4 days back, and anterolateral skull base is not a new territory for us. We're pretty good at that. But sometimes the kind of difficulties that we have with the petroclival meningioma, we would wish that we had a robotic arm, or we would wish that we had some tools where we could accelerate the drilling for the petrous apex, or do something more, seeing everything together. We wished. So I'm sure this would be the future. And I would like to sign off with that. Thank you very much.
Thank you so much, Professor Cherian. Any comments, any questions from the panel for him?
It's very impressive, sir. So thanks for the presentation.
Thank you, Dr. Aib. What name is the last robot? What name is last?
I didn't get your question.
Last slide. Last robot, which move with glasses. What name?
Yeah.
What name?
Name.
Yes.
Well, we have named it visualization robot. Visualization robot. We have named it. I mean, it's our robot, so we have named it visualization robot. Viz robot.
Okay. Thank you.
Any other questions? Dr. Leonardo, would you like to ask?
Yes, I have a question. I know when you use robots, sorry, when you use robots, you need to use software. And when you use software, you are under the control of the engineer. And why you can train these engineers to do a very good software? I mean, you know, the engineers are not physicians, are not medical. It's not easy to try to combine, to mix these two different words, medicine and engineering. What is your plan for this mistake, for this problem, for this trouble?
I know. I was in Calgary a few months back. I mean, sorry, not Calgary. I was in Alicante, where the robot is. A few months back, I was there, and it's very difficult to make the engineers understand as to what we want. It's true, but it's not that it's not doable. We can do it. They are advancing in many other fields with robotics. I mean, if you search for Boston Scientific robots, there are robots which can even do a complete flip. Uh, a robot which can walk over uneven surfaces and then climb stairs or do a complete flip and stand up on its two legs. So it's all possible. So only thing is we are not utilizing this in neurosurgery. So if the kind of skills that is being shown in robotics can come to neurosurgery, it will be a revolution. It'll be the future of neurosurgery.
Yes. I think it's a long work too. It's just the beginning right now.
Yeah. Yes.
Yes. Thank you.
All right. Thank you. So we proceed with our next talk. Dr. Sandeep Talari from India. He will be talking about cerebrovascular bypass surgery, a beginner's perspective. Dr. Sandeep? No, Dr. Sandeep, can you please share your screen?
He has to unmute.
Yeah, you're muted, Dr. Sandeep. Yes, Dr. Sandeep. We're not able to hear you.
Hear me now?
Yeah, it's very low. Your voice is very low.
Just a minute. Can you hear me now?
Yeah, we can hear you.
Yeah.
You can moderate.
Okay.
I'll get it.
Sure. Thank you.
Okay. I'm Dr. Sandeep from India. I was in Fujita.
Dr. Sandeep, your voice is very low. Can you please speak near the microphone?
Yeah. So I'm Dr. Sandeep from India. Can you hear me?
We cannot hear you well. Can you please speak near the microphone?
Yeah, I'm pretty near the microphone. Can you hear me now?
No, it's very low actually. Are you using a headset?
Yeah, I'm using a headset.
But it's really low. Yeah.
Can you hear me now? Can you hear me now?
Yeah. That's better.
Yeah. I'm Dr. Sandeep from India. I was in Fujita in 2015 for 6 months, and after that, staying there, I got interested in bypass surgery. and then I went to Dr. Takizawa's place for 3 months again to learn bypass surgery. So I think I can speak a few minutes on bypass surgery. I mean, I think I have the eligibility. Okay. So I thought this seminar was for beginners and residents and medical students. So this presentation is pretty basic. Uh, so bypass surgery is not something which is very new. Actually, it was performed 50 years ago, nearly 51 years ago, by Professor Yasser in Zurich. And before performing his first case on humans, he has done a lot of animal experiments. And after that, he has done his first STA MCA bypass. And after he has performed the first surgery, there was a decade of bypass surgeries. People were doing bypass surgeries left and right, but and initially they were done for a large number of cerebrovascular occlusive disease patients, and the patients were not properly categorized, and so there were many failures. And in 1980 there was a study known as the European Cooperative Study for Stroke, and they have found that the bypass surgery was of no great benefit for stroke. So after that, after the 1980s, the number of bypass surgeries decreased because of medical and endovascular therapy options. And as the surgeries decreased, the expertise decreased, and the present generation of surgeons, they are not very well versed with bypass surgery. So, and now there is a resurgence of bypass surgery because the indications have been widened, and more people are now learning bypass surgery. So the aims of bypass surgery in cerebrovascular bypass is preservation of cerebral blood flow. And when you, like in a giant aneurysm, when you plan to trap ligate it, or in a skull-based tumor, etc., or augmentation of cerebral blood flow, like when you have an occlusive disease of cerebrovasculature. So the present day indications for cerebrovascular bypass surgery are unclippable aneurysms, like giant aneurysms, blister aneurysms, fusiform aneurysms of ICA, and previously coiled aneurysms, which are neither amenable for recoiling or clipping. So the other options are moya-moya disease, where as a direct revascularization method instead of the indirect revascularization, and for skull-based tumors with vascular encasement like cavernous sinus meningiomas, chordomas, etc. And for cerebrovascular occlusive disease also, if the patient is properly selected, surgery can be of use for recurrent TIA and intracranial or extracranial carotid occlusion. So the types of bypass can be categorized as 4 types. The type 1 is using an interposition vein graft. For example, if the petrous carotid artery is blocked by stenosis or by a skull-based tumor, you can put a saphenous vein graft and anastomose it proximally and distally to the block. So this type of bypass is known as skull-based bypass, and it is a very difficult procedure, and it is less preferred now. So the second type of the type 2 is the extracranial to intracranial bypass using the short saphenous venous graft or the radial artery graft, and this is also presently known as the high flow bypass graft. Okay, and the third type is the extracranial to intracranial bypass using the scalp artery. Two types of bypasses are there. The superficial temporal artery can be used, or the occipital artery can be used, and these are the low flow bypasses. And the type 4 bypass is direct intracranial bypass, where you anastomosis both intracranial vessels, like you do the pica-pica anastomosis, or the A3 anastomosis, or the M2 anastomosis. So a few points to know before going to the further slides, and to know when to use which type of bypass. A few basic points which you should know is that normal blood flow of MCI is around 250 ml per minute. So
Dr. Sandeep, sorry to interrupt. Can you please be a little bit louder, because it's really getting low. Yeah.
The normal flow of MCI is around 250 ml per minute. So if you know this, the normal flow of each vessel in the brain, then you know to use which type of bypass, because the blood flow through the saphenous vein graft is around 70 to 140 ml per minute, and it may increase up to 250 ml per minute. So if you need to put a use a high flow bypass, then you have to use a saphenous vein graft or a radial artery graft, which has a lower flow than saphenous vein graft. The radial artery graft has a flow of around 40 to 70 ml per minute, and a normal STA has a flow of around 15 to 30 ml per minute. It is the same with occipital artery, but it can increase with time after a few months after bypass. So the other types of classification is like end to side bypass. It is the STMCA, and side to side, like the A3 A3. And high flow, it can also be categorized into high flow bypass and low flow bypass. So the investigations for a case planned for bypass depends on actual the diagnosis, primary diagnosis of the patient, whether it is being done for an aneurysm or for a carotid occlusive disease or for a tumor and all. So the basic investigations are MRI brain, plain and contrast, CT angiography, DSA, PET scan, and CT perfusion. So for preparing for a bypass for young neurosurgeons, practice is very important. So the main things are keep practicing, and good technique is needed to decrease the risk of thrombosis and minimize the occlusion time. The occlusion time of less than 25 minutes is the preferred occlusion time. And instruments with the basic instruments which you require for performing or practicing a bypass is you should have jeweler's forceps, microneedle holder, and suture materials from 80 to 11 ethylone. So a variety of commercial microscopes are available for neurosurgery for practicing bypass. And this is one model. There is another model in Zeiss also. This is the Leica S9 microscope, which can be bought for around $2,000, and it is good for practicing microvascular anastomosis. So a few basic instruments like two jeweler's forceps, one scissors, and one needle holder would help. And for performing deep bypass like A3 bypass or anastomosis to PCA, you need much longer instruments than the regular jeweler's forceps. So this is one variation of jeweler's forceps where the length is longer, and here you can see the tip is also curved, which helps in anastomosing in the deep. So, and also you need this rubber with 1 millimeter markings to place under the recipient vessel. This also helps in knowing the size of the arteriotomy. This also helps in, you can measure the size of the arteriotomy. The regular arteriotomy length is around 3 to 4 millimeters. And other equipment which you need are a Doppler and ICG to check for the flow after the bypass. So this is a microscope that I have at my home, which I use for practicing. And these are the basic instruments that I have at home for practicing: two jeweler's forceps, one micro scissors, and one microscope. And this is sufficient, and anyone can practice at home whenever you find time. So there are different types of artificial blood vessels which are available for practice. This is by the Muranaka company. It is a plastic type of blood vessel, but it doesn't give the actual tactile feeling. It doesn't give the actual tactile feeling of a blood vessel. And much better is the Kislex company's blood vessels, which come in various sizes: 1 millimeter, 1.5 millimeter, and 2 millimeter. This gives a good tactile feeling. And if you finding these materials that is difficult, then you can always use a chicken leg, the femoral artery, or the chicken wing brachial artery. This is what I use at home to practice whenever I find time: a chicken femoral artery or a chicken wing. So this is an example of a end-to-side bypass. So here I will show you a few videos of practice videos of end-to-side and end-to-end, and actual videos also. So all of you might be well versed with this, but it would be helpful. So here you can see this is the artificial vessel of the Kislex company. So here we have already prepared the donor vessel. We have already prepared the donor vessel. Tip of the vessel is cut in an angulated manner, and the angle is around 120 degrees. The angle you can see here is around 120 degrees. And if you consider this as length A, if you consider this as length A and this as length B, A and B should be similar. The length of A should be equal to length B. And the length of arteriotomy, should be equal to A plus B. So here we are using pyocyan blue to make the vessel more visible, and we have also stained the distal end of the donor vessel. And now this is called as the heel of the heel, and this is known as the toe. So initial stitches we take from the heel and from the toe, and first we do anchoring suturing, and then we go for the back wall and the front wall suturing. So here we are doing an arteriotomy with the scissors, micro scissors. Once the arteriotomy is done, we are using 10-0 ethylone, and the suture is placed from outside in, and for this vessel from inside to out. So the heel stitch is placed here, and then next the toe stitch is placed. Or you can even call it as 12 o'clock or 6 o'clock position. So once this stitch is placed, the next stitch is the toe stitch. The ideal situation, the ideal type of suture would be to take from the donor vessel and then go to the recipient vessel. Here it is being done in a reverse manner, but the ideal situation would be to go from the donor and then to the recipient, from outside in and then inside out. So once the heel and the toe stitches are placed, then this is the back wall and this is the front wall. Suturing the back wall first would be better, as it would be difficult if you suture the front wall first. So once the heel and the toe stitches are placed, the back wall and the front wall can be sutured in a continuous manner, or it can be sutured in interrupted manner. So here the back wall sutures are being placed, and this is the most important stitch. The stitch next to the heel or the toe is the most important stitch, because it is the site where bleed can occur, leak can occur after the anastomosis. So the first stitch has to be placed very close to the heel or the toe stitch, and this has to be placed carefully. And after that, interrupted sutures, we prefer interrupted sutures rather than continuous sutures. So the back wall is being sutured. Ideally, 8 sutures are required. But if you cannot place 8 sutures, then lesser is also okay. So once the back wall is sutured, then we come to the front wall. These corner stitches are the most important stitches in any anastomosis. So now we complete end-to side anastomosis. So, and this is a practice video for a side-to-side anastomosis. As you can see here, this is like a simulation for A3 bypass. And this rubber dam and the vessels are placed deep within the interhemispheric fissure. This is a silicone model of skull and brain. And deep within the interhemispheric fissure, the rubber dam is placed, and 2 artificial vessels are placed. And for fixation, we use pins. And we are marking here using dye, Pyokian blue. And then arteriotomy is done. Okay. So once the arteriotomy is done, the back wall has to the back wall is sutured in a continuous manner, and the front wall is sutured in a interrupted manner. You go from outside in. Here you because of the depth, it is a because of the depth, bypass is a difficult thing. So once you go in, you suture in a continuous manner. You see, I am the back wall is sutured in a continuous manner. For every stitch, you have to pull this thread so that there is good locking. So as you near the end, and you come out through the other vessel. If you have entered through this vessel, you come out through the opposite vessel. So I have entered through here. So ideally, I want to come out through here. So now the back wall suturing is complete, and both these threads are left like this after tightening. So it will be tied to the front sutures. So now the back wall suturing is finished. Now anteriorly, we place interrupted sutures. Because of the depth, the regular jugular forceps are not sufficient for this type of bypass. A longer type of jugular forceps are required, as I showed earlier. So this is the first front wall suture, and we tie it and then tie to the free thread. So we first tie the front wall suture and then tie it to the free thread. The same here at the lower end, and then in between we place interrupted sutures. So I have tied it to the loose end here, and then I go to the lower end, take a front wall suture, tie it, and then tie to the loose thread. So you can see here I am tying the loose end of the back wall suture. This is the loose end of the back wall suture, and it is being tied to the free end of the front wall suture. So once the threads are cut, then it is pretty simple. You have to just suture the front wall of both vessels and in an interrupted manner. So so here we have completed the suturing of the front wall in an interrupted manner. So this is a small video of an actual case of STA MCA bypass. This was not performed by me, but it was performed by my mentor, Dr. Takizawa. So I am demonstrating his technique here. So there are two ways of isolating the STA. One way is marking out the STA using a Doppler and incising directly the skin over the STA and isolating the STA. The other way is raising a flap and dissecting the STA from the galea, subgaleally. So we prefer the subgaleal technique. We don't prefer the direct incision of microscopic visualization. You can see the STA is identified. This is the cutting bipolar forceps, and the skin flap is raised, and the STA is being separated, and the one end is cut, and it is irrigated with heparinized saline, and temporary clip is placed. So then we go for the craniotomy. We open the dura, and then we find the suitable vessels. The ideal vessel for as a recipient should be at least 1 millimeter in size, 1 millimeter of diameter. So in this case, we are doing a double bypass, that is double barrel bypass. So we have identified two M4 vessels and place the rubber dams under the M4 vessels. So and next is the preparation of the donor. Next is the preparation of the donor. So the donor, the at least 3 to 4 millimeters of the donor distal end should be prepared. That is, all connective tissue for at least 3 to 4 millimeters should be removed, and then it is cut. In an angulated manner. And as I showed earlier, fish mouthing is done. So here the recipient vessel is being dissected. The arachnoid is cut, and the recipient vessel it should be at least of 1 millimeter diameter. So suitable vessel should be identified. And if you cannot find a suitable vessel within your craniotomy,
Dr. Sandeep, I'm sorry for the interruption, but we are running a little behind time. So if you can just wind it up in the next couple of minutes, please. Thank you.
So here you can see the anastomosis being done. And finally, the clips are being removed. So this is a video of high flow bypass, but I cannot show it because of lack of time. If someone is interested, I can forward it to them if they send me their mail ID. So in the conclusion, the cases for bypass have to be chosen very carefully. Otherwise, you will experience a lot of failures with bypass. And the occlusion time has to be minimum, preferably less than 25 minutes. And technique should be very gentle to prevent occlusion of the graft. And this is a picture of Dr. Takizawa teaching me how to do bypass. And after teaching, I'm performing it. So this is a picture taken when I was in, it was in 2015 in Fujita. Thank you all for patient hearing. Thank you.
Thank you. Thank you so much. Any questions, anything regarding bypass? Any comments from the panel?
Yes,
Okay.
I have a question. What kind of material you use to practice in the laboratory? I mean, this is small kind of basals. What kind of material you use to practice?
When I was in Japan, Professor Takizawa used to give me artificial vessels. You can check for Kezlex. It is K-E-Z-L-E-X. K-E-Z-L-E-X Ono, O-N-O on internet. Okay, it is more like human vessels. It is more like human vessels. The tactile feeling you get while doing an anastomosis is more like a human vessel. But back in India, we don't get this material, so I use chicken leg or wing.
Okay, thank you.
All right. Any other question?
Yeah, it's very good presentation. Thank you, Dr. Sandeep, to let us know, to the practice the bypass surgery. Thank you.
Dr. Itijai, can you repeat that, please?
Can you hear me?
Yeah, we can hear you now. Can you? Yeah, please repeat that.
Yeah. I just want to say thank you, Dr. Sandeep, to let us know about the techniques. We can do it.
Okay.
Thank you.
Thank you so much. Thank you, Dr. Sandeep. So we proceed with our next speaker, Dr. Thomas Tommy. He is a neurosurgeon from Indonesia and will be talking about fusion images in neurosurgery. Dr. Thomas?
Good evening. My name is Thomas. Is it a good reception of the sound?
Yeah. Sound is fine. You need to share your screen, please.
Okay. So, this is only a simple presentation regarding fusion images. So advanced topics has been mentioned by Professor Ibe regarding the OR system and robotic neurosurgery, and also Dr. Divya for the CFD. I just want to mention regarding the role of the fusion image in neurosurgery. So it's simple topics and probably not taking so much time. As a disclaimer, there is no conflict of interest regarding this presentation. And so what we know that technology in neurosurgery is collaborations between engineering science, medical science, and information technology. Like engineering, they research and develop all the instruments and all the computer works for diagnostic and also for therapeutic therapy. And medical science is also, we know that the science is still growing. So with those collaborations will make a good difference, like for for advancement of the our medical health. So for history, X-rays was founded by Wilhelm Röntgen about 1895, but CT scan was developed by Hounsfield, and then MRI by Lauterbur around 1973. So there are no development between those times until the present that change our approach to the treatment of illness, especially in neurosurgery. So this is to make it simple, like the progress of technology, we can see for an example, television or monitor. In the old days, they use bulb television, and the first time is black and white only. Then they develop colored ones. Bulb television then changed to flat panel television or monitor. As we know, there were LCDs, plasma TV, and nowadays LEDs. And also the definition is getting crispier and more, higher definition, like 4K or ultra high density, or ultra high definition, But this, if we compare with the radiology, at first they use films. Then after that, they develop filmless radiology using digital imaging. Then they develop PAC system for, system that you can enter or you can take the data of any radiology in your hospital. And also their monitor of radiology is getting also better by the advancement of technology. So if we combine this modality, then we can answer the problems or questions that anatomical images are not the same with surgical or microsurgical view. That is the problem. So radiology will give us anatomical image. So they will send AP view or lateral view. That those images are not in microsurgical view. So as a neurosurgeon, we have to develop our own approach into for the image. So we process ourselves that those image will conform with our microsurgical approach. So as this is interesting journal, the topic is about image-guided neurosurgery. And image-guided neurosurgery is a neurosurgery that is literally guided by the image. So integration of imaging with surgery in the planning, execution, and post-operative assessment. And pre-operative planning fusion is we can combine CT and ultrasound. We can combine CT and MRI, SPECT and CT, PET or PET or with CT. Then with a workstation, we can do a co-registration, and that is named by fusion images. And acquisition usually for this presentation, for an example, is being taken in Japan. So they have Philips MRI and CT angiography using 64 slices CT. And also the DICOM is fused in a workstation. The problem in this setting is not just the device. So I know that many hospitals already have MRI, CT, but the workstation has a special software for fusion image, and that software will cost. That software is expensive. So this is the co-registration process. So MRI and CT, they fuse it in the workstation, and like if you can see the bottom right corner picture, they diffuse DWI image with CT and CT angio, and this picture they develop for to make an approach by developing 3D image to identify important structures to avoid and the target of operation. But this is still this picture is are still in anatomical view. So in Japan, I take some example. So this is a case number 1, a trigeminal neuralgia case. So if you see the left side, it's dolichoectatic vertebral arteries and vascular arteries. But the problem is on the right side. If you see that there's a pica elongated and contacted the fifth nerve. So we can, by using fusion image, we can rotate the image in the workstation and see 3D. So we can maneuver the picture and see which one or which part is the problem. And if we make the orientation into surgical view, we can see like this picture on the left is the fusion image. Red is the vessels and the yellow is the nerves. We can identify that the offending vessels as pictured. And on the right side, during surgical view, we can see that it confirms the vessel that offended the nerve is the same with the pre-surgical simulation. And And this is for hemifacial spasm. So they join also 3 modalities: MR angio. This one is MR venous, and CT angio and DWI. This is the orientation of the surgical view, and the same problem here is the offending vessel can be identified, and microvascular decompression was done. And this is for also trigeminal neuralgia again, and we can see that the vertebral arteries pushing the 5th nerve on the left side. This is the surgical view, and we can see that it confirmed with the surgical, during surgery, the same picture with pre-surgical simulation. So to keep it short, as a conclusion, for me, modern imaging technique like fusion image helps surgeons to have pre-surgical view, not only for vascular, but also for tumor surgery or any surgery that needs navigation for to approach the lesion. And preoperative simulation is useful, like the one Professor Sano said, that before you do surgery, you finish the surgery in your imagination. I think that is the end of my presentation. Thank you. Dr. Hira?
Okay.
Yeah. Thank you. Thank you so much. So any questions on fusion imaging? Any comments by the panelists? Dr. Ichtai, would you like to add something to this?
Yeah. But the fusion image in our country may be difficult to perform because it's from their economic system or some problem. But in Japan, I know it's not expensive. But if we have the machine, maybe we can proceed like this imaging is helped us too much to perform surgery. Thank you.
Okay, thank you. And do we have Dr. Abdul Rahman with us still? What are the, how is it in Tayumin? Ibrahim, can you highlight on that?
What? Repeat, please.
The role of the use of fusion imaging in Tayumin in your setup.
MRI is Tesla, 3 Tesla, maybe. No,
okay.
3 Tesla CT and O arm and C arm. That's all.
Okay. All right. So we proceed with our last talk for the day. Just let me confirm. We have Dr. Ichitai Sakaranjai. He will be talking about cerebral aneurysm management. He's from Thailand, Department of Neurosurgery, Prince of Songkhla University, Songkhla. Dr. Ichitai, thank you so much for your talk. Yes, please.
Okay, good evening, everyone. My name is Ichitai. I am the first student, first fellowship from Bantane Hospital with Professor Yoko Kato when she moved to this hospital. So today I will talk about the how to management of cerebral aneurysm, but I just reference in the basic of the principle to treat. As you know, now there have the many devices that can assist the aneurysm surgery. So today I will conclude it about how to treat or how to prepare about the pre-op, intraoperative, and post-operative treatment. Because of most of the patient came to the hospital with diffuse subretinal hemorrhage like this. But as you know, the effects of aneurysm rupture
It depends on the volume of subarachnoid and clinical grading. This condition will cause of increased intracranial pressure, hydrocephalus, or seizure. But the pathologic change, they have the effects to the systemic. Because at that time, the aneurysm can cause about many like hypermetabolism in every organ, especially in the heart and in the lung. Because the increased ICP from aneurysm breathing may be decrease of 0.4, and the patient have the brain ischemia and further brain damage. So we should prevent the rebreathing after we can see the patient have the subarachnoid hemorrhage. For the preoperative management, as you know, the high blood pressure prevention, this is the best one to prevent the aneurysm formation. And also, if we in stroke 2012, they proposed about if we can eat the vegetable, maybe we can decrease the risk of rupture aneurysm. Because of aneurysm rupture, we can diagnose for 3 modalities: for cerebral angiography, CTA, and MRA. Then we definitely treatment by keeping or coiling. Because the AA guideline, they recommended to use the CTA or MRA or DSA. But for the simplest way, we can diagnose by CT non-contrast. If we not see the subarachnoid hemorrhage, we should LP first. Then we bring the patient to perform the vessel angiography. For prevention of the rebleeding, we should keep the systolic blood pressure less than 160 mmHg. At the ER, if we found the patient was diagnosed subarachnoid hemorrhage, we should evaluate about the vital sign. And don't forget, because as I mentioned before, this aneurysm rupture can cause about the systemic effect. We should examine the heart and the lung, and we perform the EKG. Then we complete the neuro examination, and we keep an IV and group mat, and perform the chest X-ray and admit the patient at that time. And from the CT scan, we should know the fissure grading of the patient at that time. What is this? Because the different grade is can predict about the outcome of the patient. Because the grade 1, it can cause the vasospasm, 21%, and the grade 3, this is the most of vasospasm, cause more than 37%. And we devise the clinical evaluation, because the grade 5, the survival only 10%. For the preoperative, I think we know everything before, but I want to acknowledgement in some monitoring. We should record vital sign every 1 hour and record the intake output and take dose and monitor airline. If we can perform the CVP insertion if the patient have some we want to have the IV infusion. This is my patient. The patient have the hypertension. At the admission, I give about the nicardipine drip and insert the airline monitoring. And be careful, you should tell the nurse. At that time, we avoid to put the forehead catheter or NG tube, because it's a stimulant about the pain, and aneurysm can cause the rupture. We apply the EMRA. This is the local anesthetic in the puncture site, because it can decrease the pain when we puncture. This is the angiographic room that I bring the patient, and I just want to know which is the exact of the location of aneurysm before go to the treatment. This is the medication that we keep. The blood pressure is less than 160 millimeter mercury, as I mentioned before, and we can give some medication like a cough suppression or anti-epileptic drug. This is the order at my hospital. We keep very strict about the blood pressure, and we prescribe about the drug anti-cough and stool softener because it prevent the patient have aneurysm rupture. So the nicardipine we can titrate until the maximum about for 15 milligrams per hour for the control the blood pressure. So the special situation we should avoid about the hyperthermia, hypo and hypertension, hypo and hyperglycemia, and we should avoid about the hypovolemic state. For the progress of the patient, we should treat or not at the time, because if we delay for treatment about the progress of the patient, maybe the death rate is reached to 70%. If we aggressive treatment, the death rate decrease to 50%. This is the most important point why we should treat the progress. I mentioned before, we should prefer endovascular treatment because at that time the hemodynamic that is not good for perform clipping of the high gain. Because if we see the patient have the high grade, we should coil or clipping as soon as possible. So clipping or coiling, in my hospital we prefer the microsurgical clipping in the circulation and the good clinical at that time, at the first time, and not too old, we perform the clipping. And coiling for posterior circulation, I prefer to treat with endovascular coiling, or the patient very old. At that time, we perform the we should not perform the surgical clipping. For intraoperative management, this is the operative room. We should have the microscope and the good device. And if we have the hybrid operation, we can do it for in this room, because we can monitor if sometime we have some accident during dissection. The endovascular treatment at the time can be helpful. How to avoid about the surgical complication. For the vascular injury, we should avoid about the perforator artery injury or the premature aneurysm rupture. But for non-vascular injury, we should avoid the focal brain contusion or the cranial nerve injury during surgery, because the vascular injury during surgery, the most incident occur during dissection or the clipping techniques. For the synovial dissection, we should use spatula, but we should perform only mild retraction, because if we perform the heavy retraction, maybe the cause of the brain contusion like this, and we have to open the arachnoid membrane as carefully. Finally, we can see about the aneurysm or the parent artery that's close to the aneurysm next. And finally, if we enough to dissection the synovium, we can easy to clipping of aneurysm like this. For the complication, as I mentioned before, because we compromise about the parent artery, maybe the patient have some symptom of stroke or thromboembolism. We should have about the intraoperative Doppler microsurgery on all ICG, because the ICG can help us to confirm the aneurysm morphology and the complete obliteration. For endoscopic, just optional because in Japan they use in every case, but in my country we don't have this device during the surgery. Or the MEP also can monitor about the perforator artery injury during clipping. For the microscope, the Flow 800 can help us because they have like a color maps that we can confirm us about the clipping complete or not. If it can still have the flow around the clipping area, that means we not complete obliteration of aneurysm like this. For the new device that I have published before about the endoscopic from the Stord company, they can provide like a blue light like this. We can mobile about the endoscope during clipping, and we can confirm it's complete or not after clipping. Or the DIWA, that means for ICG we can see about the white and black, but for DIWA we can see about the green one, and we can confirm also about the structure around the aneurysm. Okay, I will move fast because the time is gone. This is the special situation. If we found this atherosclerotic in the wall of aneurysm, we should avoid to clip it because it can cause about the aneurysm. Okay, this is in my case. I use the ICG and clipping aneurysm at that time, like this. If we can practice in many cases, maybe it's not too difficult for us. For post-operative care, we should control the blood pressure, and we should give about the nimodipine before, because prevent of about vasospasm. This is for sending order of my patient. We usually to perform the head elevation and on the pneumatic cup compression. And the monitoring, we should have the invasive monitoring from the arterial or for the A-line, CVP, or non-invasive blood pressure measuring. And the internal CO2 can help us about the monitor about the vein edema. This is my patient. Every patient have a pneumatic cup compression during surgery because preventive vein thrombosis or pulmonary embolism. So the vasospasm, as you know, because vasospasm is nearly 80%, 90%, and the onset may be until 2 weeks. I also use the TCD to diagnose about the cerebral vasospasm, and the keep about the blood volume intake more than 3 liters per day. And for vasospasm, it can cause a vein edema like this. Maybe we can use about the endovascular technique, about the navigator microcatheter, and give about the nicardipine. It can help us to decrease the severity of vasospasm like this. So I will go about the conclusion, because if the patient that present about the seizure, fever, or myocardial infarction or anemia, we should concern about the special condition that associate about the aneurysm rupture. So we should treat the patient as soon as possible. At the first thing, we should perform the CT non-contrast and admit the ICU and perform the full vessel angiography as soon as possible. Then if the patient have the poor condition, we should bring the patient to perform the coiling. If the patient have the good status, we should select the patient to perform the clipping. as soon as possible. So I just want to announce all of you to attend my congress in next year in Phuket about the minimal invasive neurosurgery. The course will be organized on the next October. If you have a time, please visit in my country. Thank you.
Thank you so much, Dr. Ititai. It was really good. Any comments? Any questions? We see two new panelists. Hi, Donnie. Hi, could you please introduce yourself, Donnie?
Let me unmute him, Hira. Okay, go ahead.
Yeah. Hey, Donnie, can you hear us?
There you go. Okay, Donnie, please introduce yourself.
Yes, thank you all. I'm Donnie from Indonesia. Hello.
Hi, yeah, we can
Hello.
hear you, yes. Please introduce yourself.
Yeah, I'm Donnie from Indonesia.
Okay.
Are you a resident?
No, I'm a neurosurgeon.
Oh, okay. Welcome to the panel. Welcome to the panel.
Thank you.
And we see Voralex. Hi, Voralex. You came late in?
Hi from Thailand.
Hi. How are you?
First I would like to
please introduce yourself.
Hi everyone. My name is Paula. I'm the president from Indian University. It's nice to be here.
Oh, hi.
All right. Welcome. Any questions, any comments from the panel for this presentation on cerebral aneurysm management? So I think that is it. Dr. Itichai, you have to stop the screen share and we end our symposium here. I would just like to take a few more minutes and introduce to you about the student society which we are running. Dr. Itichai, could you please stop the screen sharing? Yeah. So just give me a moment to introduce to you about the AMSRS. This is our students society run under the auspices of WFNS and the Asian Congress. I would like to invite you all to our upcoming symposium, which is held this month on November 29th and 30th, exclusively for medical students who are in their final years and who would like to pursue neurosurgery. I'll just, can you see my slides, John?
It will also be televising that, Hira.
Yeah, that will be televised live on Neurosurgical TV. So this is our program. We have faculty coming from, Professor Kato will be coming. We have faculty coming from Japan, Pakistan, Brazil, China, India, England, Africa. It's hands-on. We are focusing more on microsurgical anastomosis and drilling techniques for young neurosurgeons and medical students as well. This is our program, and we would like to invite you all to come over Nepal and have a look at this center on neurosurgery. It's set up in a place where the resources are less, but we have managed to build up a center to provide the best of neurosurgical care under one unit. So you're all welcome and be a part of this society, and we look forward to having more of such webinars. Thank you all. We are done for today. Thank you, John.
Thank you, everyone.
Thank you, Dr. John. Bye.
You can go offline.